Good evening, everyone. Welcome to tonight's webinar. My name is Kelly Wharf, and I'm the Practice Success Manager at TendoNova. I'll be your MC for tonight, and I'm excited to have you all here for an insightful discussion on tendinopathy. Before we dive in, I just wanted to share a little bit about TendoNova. Our mission is to bring innovative solutions to the orthopedic space with a focus on improving outcomes for patients dealing with tendon pathologies. One of our co-founders, Jonathan Shaw, he's here tonight, was a practicing physical therapist for 10 years before transitioning into the med tech industry. So we're deeply committed to bridging the gap between clinical care and cutting edge technology. And now it's my pleasure to introduce our speaker, Jarod Hall. Jarod is a highly respected physical therapist with OCS and CSCS certifications. He has extensive expertise in orthopedic rehabilitation, pain science, and clinical education. Jarod regularly presents national and international continuing education courses for physical therapists, occupational therapists, and chiropractors. And he also developed and leads an orthopedic board specialty examination preparatory course through Optum Manual Therapy and Fellowship. We're incredibly fortunate to have him here today to share his knowledge on evidence-based approaches to tendinopathy. Just a little bit of housekeeping. Please use the chat function to ask any questions you may have throughout the session, and then we'll save all the questions for a Q&A session at the end of the presentation. All right, with that, let's get started. Jarod, over to you.
Kelly, I appreciate it. Thank you for saying all the kind words about me, whether I deserve them or not, but I appreciate it. And everybody out there, I appreciate you guys spending the time to jump on and actually learn a little bit more about tendinopathy and tendinitis and TendoNova as a company as well. So tonight we're going to be talking a little bit about just tendinopathy as an umbrella concept and what does the most recent research say about tendinopathy? How do we maybe go about load management? How do we go about the most evidence-based approaches to managing tendinopathy, in particular chronic tendinopathy? So just a little bit about me. Kelly mentioned this, but I run an Optum Fellowship Orthopedic Board Specialty prep course. I'm a faculty member in the orthopedics department of the local physical therapy school here in Fort Worth, Texas, at the UNT Health Science Center. Background, I did my undergrad at Texas A&M, and then I went straight into PT school here in Fort Worth. Became a board specialist almost 10 years ago. Unfortunately, I'm going to have to renew my board specialty next year, so that's never fun. I did want to disclose the fact that I am a member of the medical advisory board for TendoNova as a company, that I help consult on all things tendinopathy, physical therapy, and rehab. And then, of course, I do have a small financial stake in the orthopedic board prep course for Optum. So I just wanted to make sure that those things were known. So what are we going to talk about tonight? We're going to talk about really kind of our history and evolution of tendinopathy and what we understand about it, talk about prevalence, economic impact briefly, risk factors for developing tendinopathy, the pathophysiology of tendinopathy was where we're really going to get a little bit deeper into things, then evidence-based treatment strategies, and we'll wrap up with some final takeaways, and we'll end off with a little Q&A for any questions that you guys might have or want to discuss in deeper detail. So if you look back at the history of our understanding of tendinopathy, it's a relatively young condition from the perspective of how long we've been studying it and how long we've been gathering research and really integrating our approaches in an evidence-based practice model. So really, like before the 1970s, tendon pain was thought to be purely inflammatory related. So we just called it tendinitis. And, colloquially, just in general, people call it tendinitis anytime they have a tendon that seems to hurt. But then you fast forward a little bit and we start doing some histological research, and you see that there actually aren't a ton of inflammatory markers in tendinopathy, especially chronic tendinopathy. You'll see some inflammatory markers in that acute tendinitis, like say you had a guy wake up and go out and run 10 miles when he's used to running 3 miles, and he gets that acute Achilles tendinitis, and there's some swelling and there's some active inflammatory markers there. But as we see tendinopathy become chronic, what we see is those inflammatory markers actually kind of fade away, and they're at a very low level. So this isn't maybe a condition that's driven by inflammation. Maybe it's driven by other underlying factors, and we'll talk a little bit more about that later. So then in the 1990s, the whole term or idea of tendinopathy was coined because people started to recognize, well, you have that acute tendinitis type thing where there's inflammation. Then you have that chronic tendinosis where maybe there's some degeneration of the tendon quality. There's some torn collagen fibers. The inflammation has kind of died down. The healing process seems stalled. So then in 2009, there was a model proposed by Jill Cook, in particular, who's a phenomenal tendon researcher out of Australia, who they proposed the continuum model of tendinopathy. And they kind of broke it up into reactive tendinopathy, which is what I was talking about with that acute inflammatory process when you go out and you just way overdo it and you get that immediate flare up. And then you have stage two, which is tendon disrepair. So that acute tendonitis kind of gradually hangs around. Maybe people aren't living the most healthy life. Maybe they're not regularly loading their tendons and keeping them healthy. Maybe they're, overloading repetitively in certain ways. And you get this gradual kind of structural disorganization of the tendon fibers, the collagen fibers that progresses over time. And then on the far end of the bell curve, and honestly, this is where most rehab professionals, especially, end up seeing patients is in that degenerative tendinopathy stage where you have pretty severe collagen breakdown, and these folks have been dealing with pain for a long time. They've tried a bunch of different interventions. They've tried, steroid injections. They've tried over-the-counter anti-inflammatories. They've tried acupuncture, whatever it may be, and it's just not going away. They're just struggling with this chronic long-term tendon problem. So things like, tennis elbow, lateral epicondylitis pop into mind, chronic patellar tendinopathy, plantar fasciitis, long-term Achilles tendinopathy. You can think of a lot of conditions like your insertional gluteus medius tendinopathy that fall into this category where people just deal with pain for a long time and it's so hard to get rid of. So this is just a little visual representation of that continuum model that Jill Cook and team came up with. So on the left, you have that healthy tendon model, and then you have a little bit of reactive tendinopathy, which maybe if it hangs around goes into the early stages of tendon disrepair. And in general, this is where, we're pretty good from a medical side of things. We're pretty good with rehab of these folks. It hasn't gotten off the rails yet. We don't have this chronic degenerative problem. So a lot of times these people respond pretty well to conservative approaches, whether it's, a combination of if it's just reactive, a little bit of rest and then kind of reintroduction into their regular activities, or, maybe a little bit more targeted and focused rehab with a progressive loading scheme and maybe some modalities and that sort of thing to help manage their pain. Over on the far end of the spectrum, in the degenerative tendinopathy category, this is where just as a medical institution, historically, we've not really been that good. And in particular in PT, I know that I've seen some of these folks and it's frustrating. The progress is so slow, or you don't even see progress from visit to visit or week to week, or sometimes even month to month. These people get frustrated. They just have this pain that won't go away. This is just in general where we're not super good. And, there's some research studies coming out now that kind of show maybe even if you do, a rehab-based approach at 10, 12, 18 months later, there's no real difference of if you just let it be or if you did some sort of targeted approach. And these are the ones that frustrate the heck out of us. I know that they've been tough for me in clinic over the years. So let's talk about how common is this stuff? Like how many people are actually dealing with tendon related problems? Uh, it was actually, when I started digging into this research, it was more than I realized. So if you add up all of these individual prevalence rates and you start talking about rotator cuff tendinopathy, medial lateral epicondylitis, patellar tendinopathies, all this sort of stuff, you're getting up to close to 40 million people on the prevalence rate. So we're talking like over 10% of the population could be struggling with tendon related problems. And a lot of these are pretty chronic. A lot of these are things that don't just like show up and go away in a week or two. They hang around for months or maybe even, years in some cases. So what's the economic impact? So we just look at direct medical costs. I believe this data is from about 2 years ago. estimated annual medical costs for directly treating tendinopathy exceeded $2 billion just in the United States. So that's a pretty large chunk of change. And then global expense on tendinopathy, we're kind of projecting that that's going to be $280 plus billion just by the year 2030. And then that doesn't even factor in the indirect medical costs that are associated with tendinopathy. So when you start to factor in that 70,000 workers in the US miss work every single year from tendinopathy, you get a pretty big financial impact from, quality adjusted life years being impaired, employer lost costs, employee lost costs and lost wages and time off, and then plus their medical expenses, and plus maybe some of the other non-tangible costs that go into dealing with chronic tendinopathy. So it's kind of a big deal. It's pretty significant when we talk about overall healthcare expenditures, especially in the musculoskeletal world. So, what are some of the risk factors for tendinopathy? Well, you'll see based on some of the risk factors that all the data shows, we're having a progressively increasing rate of tendon problems because we have age, genetics, and metabolic conditions that really heavily influence whether or not a person will get tendinopathy. Age and genetics are something that have been around forever. We can't really change that. But the big factor that's been going on in recent decades is, in general, our metabolic health is pretty terrible, in particular in the United States. So as we see a lot more metabolic dysregulation, we see a lot more diabetes, we see a lot more hypercholesterolemia, we see a lot more obesity. Everybody first thinks about, oh, well, that's just more load on the tendon. That, heavier people, they put more load through their tendons, but that's really not the whole story. When you have chronically elevated blood glucose and you start to have the adaptive changes to the metabolic system, what you get are a huge spike in AGEs, or advanced glycation end products. And these are nasty little buggers that float around in your bloodstream, and they actually hate connective tissue. So what they do is they make connective tissue a little bit stiffer, they make it a little bit less resilient, they make it a little bit less elastic, and they kind of help to like spur on that degenerative process. So if we factor in all of our metabolic conditions and how that continues to progress over time, we're just going to see more and more and more tendinopathy. And then extrinsic risk factors, the normal stuff that all of us in the rehab community, in particular the medical world, know about: anatomic variances, people that are on what I like to call the ends of the bell curve. We know that there's a lot of normal anatomic variants that the body can very easily adapt to. But these are the folks that maybe, just by nature have incredibly high Q angles, or incredibly low arches, or very, very genu varus knees, or maybe the angle of inclination at the neck of their femur is a little bit different, and these cause loading problems that are more on the extreme side. So they have a natural predisposition to transmit a lot of load to certain connective tissues that maybe just don't tolerate it well over time. We have stress shielding and repetitive loading. So in a lot of injuries, we see stress shielding and we see adaptive mechanical changes. So let's say if your knee hurts because of, you've got osteoarthritis in your knee, or you start walking a little bit differently, you start walking on a stiff leg as a result of that, and you're going to transmit more forces to other parts of the body, to other connective tissue sites. So because we have a problem in one area of the body, we get a dramatic increase in forces in another area that's not able to tolerate it. And especially when you layer in some of those metabolic factors. Again, poor recovery, abrupt mechanical changes. So think about somebody that recently had their hip replaced and their leg got a half an inch longer all of a sudden. A ton of those people go on to develop, lateral hip pain syndrome, which most commonly is insertional gluteus medius tendinopathy, or a chronic tendinopathy at the tendon bone interface at the posterior aspect of the greater trochanter. So we see a lot of these things as well. And then, of course, the classics, medications, certain antibiotics like fluoroquinolones are well known to cause tendon-related problems. And we've gotten a little bit haphazard with the usage of corticosteroids as well. Kind of just, you get an injection, you get an injection, you get an injection. And then you've got all these people that we're accelerating that chronic, degeneration of their tendon. So what about the pathophysiology? One of the main things that you see right off the bat is collagen disorganization. So if you look at a tendon under a microscope, it's beautiful, it's pristine. If it's a healthy tendon, all the collagen fibers are aligned. They're actually in little bundles. So you have little collagen fibers that are wrapped up into little bundles that are all spliced together. And that essentially creates a rope-like environment where all of the force is transmitted across a nice, big, healthy tendon. Um, when we start to get tendinopathy, we see the picture over here on the left, all of the collagen fibers get a little bit disorganized. So instead of being nice and straight and rope-like, they're a little bit zigzaggy. They're not as good at transmitting load. They're not as good at tolerating load. So as you get some of that chronic degeneration and disorganization of collagen fibers, what ends up happening? You end up getting a lot more overload to the healthy fibers that are remaining, and you pair those two things together, and you're going to end up in a situation where you've got chronic tendinopathy. You've also got a failed healing response. So the tenocytes, they get overloaded and they go into their natural biological processes of trying to stimulate healing, but oftentimes that just doesn't work. And what ends up happening is you get an immune response. That immune response kind of signals for increased neural growth and increased vascular growth. So when you have this immune and neural response, you get this ingrowth of all of these little nerve endings, which end up making the tendon in that area dramatically more sensitive to load. So if you guys are familiar with the term nociception, you get all this big increase of nociception or nociceptive capacity at that tendon area because you've got all of these little bitty sensitive nerve endings that have grown into that area. And then the same thing, you get this angiogenesis in the area that doesn't seem to be related to healing or helpful for healing at all. And you get a big increase in catabolic cytokines. So not only are we not healing, but we're actually getting catabolic pressure in that area as well. So we're getting a little bit of breakdown or excessive degeneration just based on that normal, natural, attempted or failed healing response. This is what I kind of mentioned before about the neuralization and the angiogenesis that occurs, and it gradually infiltrates, especially the outer layers of the tendon. So if you think about the paratendinous sheath in particular, the little protective layer that encapsulates the tendon, you get a huge amount of hypervascularization there. And you'll talk to surgeons or you'll talk to people who have done these procedures and they open a person up and they look at it and they can just see this big red, like angry looking tendon rather than a nice white pristine tendon. And that's that chronic hyperneuralization and hypervascularization that happens over time. And that just leads to a tremendous amount of pain sensitization. So what's the outcome if somebody has a lot of pain when you put load through a tendon? They don't want to load the tendon, right? It hurts really bad. So that makes rehab super hard because it's very uncomfortable, it's very painful to start loading a tendon that's been peripherally sensitized due to these adaptive changes. And they actually stress shield. They work away from it. They try to find ways to actually offload that tendon, which in the long term doesn't help it because an offloaded tendon doesn't get a stimulus to actually improve its collagen, its collagen structure. Collagen is a molecule that it needs tensile loading. It needs to be pulled on to actually stimulate it to get stronger, stimulate it to be healthy, stimulate the fibers to lay down in a nice, organized manner rather than that big disorganized manner. So that's actually really, really key to chronic tendinopathy. And it's likely one of the reasons that chronic tendinopathy is so recalcitrant is you have this really nasty neural ingrowth in the periphery that makes that sucker so tender that you don't want to load it and it's super painful. So people offload it and that actually makes the problem worse. The tendon continues to degenerate faster after that. So there's a theory that came out. It was proposed by Sean Docking, who's a really close researcher with Jill Cook, who came up with the tendon continuum model, and they've proposed this concept of donut holes in the tendon. And so what they're saying is, if you took a tendon, let's say the Achilles tendon, and you transected it and you looked at it longitudinally, you'll see, and especially around the outer periphery of the tendon, closer to where maybe some of that neural ingrowth is, but through the tendon as well, you'll see all of these little plugs or all of these little donut holes in the tendon, which are areas of really unhealthy or degenerated collagen fibers. And those unhealthy or degenerated collagen fibers, they no longer transmit load very well. So there's the idea that a lot of times with rehab and loading, we're not really able to, target those degenerated fibers very well. So we want to try to target the donut and not the hole. But in a perfect world, we'd be able to fill in some of those donut holes. So if you imagine that, 95% of the tendon is healthy, but you've got 5% that's really unhealthy through it, what we would like to do is be able to fill in those donut holes, maybe regrow some of that collagen, and overall improve the loading capacity of the tendon so it gets overloaded less easily. So if we're looking at evidence-based strategies, you guys have already heard me talk about load and progressive loading several times, and we're only like 10 or 12 minutes into this presentation at this point, right? If you dig into the research, what you'll continually see is that exercise-based rehab is pretty much the gold standard for, early to maybe mid-stage tendinopathy. Things like isometric exercises, they're effective for reducing pain. They seem, if you look at some of the research from Ebony Rio, who's another researcher out of Australia, you see that maybe isometrics are really good for reducing pain because they inhibit cortical pathways that are related to pain. These are really, really useful exercise approaches for reactive tendinopathy, or that early stage where it's really nasty, flared up. It's actually got inflammatory markers in it. Um, and then, of course, historically, if you look at the Alfredson protocol and a lot of the early research that's been done on tendon-related issues, the utilization of eccentric loading has shown to be pretty helpful. Now, there's a debate about whether eccentric loading is better than heavy, slow resistance training, but historically, eccentric loading has proven itself to at least be pretty decent. But in particular, there's some newer research showing that if you're doing eccentric loading or isometric loading or heavy, slow resistance loading, you need to target a tendon strain level of about 6% of the length of the tendon. So if you're not targeting a tendon strain level of 6%, which actually equates to using about 75% of one rep max and going through a full range of motion, you're probably not going to do very good at stimulating collagen production. And in particular, when you're doing those repetitions at that 75% strain rate, most of the research shows that you need to have about 3 seconds of time under tension for each one of the repetitions. It's kind of like a threshold level. It's not an all or none type thing, but you start to get to peak effectiveness if you can have the time under tension be about 3 seconds on these reps. So, historically, reactive tendinopathy, mid-stage tendinopathy, we have pretty decent research to show us that these exercise approaches using isometrics, eccentrics, and heavy, slow resistance training are pretty good. One of the things I wanted to talk about is a researcher named Keith Barr. He is out of UC Davis, I believe, in California, and he spends his entire life researching tendon structure, tendon pathology, tendon histology, and that sort of thing. And what he's seen is, it appears that if you think about that tendon cross section and you look at the donut and the hole, human beings, just by nature, the way that our body works, we're really, really good at stress shielding a tendon, meaning we can still use that Achilles tendon, but we're going to drive all of the force through the good fibers, the healthy fibers, and we're going to completely offload those fibers that aren't, really super healthy. They're disorganized. And what we've seen, or what some of Keith Barr's research has showed, is that if you do max effort isometrics and hold them for an extended period of time right before you go into other loading, you get a hysteresis effect in the tendon, or the natural extensibility of that soft tissue elongates just a little bit. and you actually override some of the cortical disinhibition that is stress shielding the degenerated parts of the tendon, and you can actually start to maybe load those donut holes a little bit better. This is an early theory, but it's got some promise and it makes a little bit of sense. So I encourage you guys, if you're interested, to go maybe read a little bit more of Keith Barr's work on the topic. But I wanted to give an example of what that looks like. So if you've got a muscle right here and it's pulling pretty aggressively through the tendon and it's anchoring into the bone, what the tendinopathy, especially chronic tendinopathy presentation looks like is you've got some healthy fibers and you've got some degenerated, unhealthy fibers that are disorganized, and they are not transmitting any load at all. They're basically like these empty plugs or empty donut holes. And in a perfect world, what we would be able to do is actually start to load these fibers again or do something to stimulate those fibers to heal more. So we want to, not only have our healthy tissue get better and stronger, but we want to try to stimulate healing in our unhealthy tissue and start to figure out ways to load that. So all of the load from the muscle, it's transmitted via the healthy tendon, the healthy fibers in the tendon, and it's not transmitted through the fibers that actually need it the most. So they don't get any load through the donut holes. No stress to those fibers means no incentive to heal. So then we continue on. And I want to say that I stole some of these pictures from E3 Rehab, my guys over there, Sam Spinelli and some of his team, because they had some excellent pictures and excellent progressions on getting to higher level heavy slow resistance loading, which still follows the same principles as eccentric. You're targeting at 6% tendon strain or 75+% of 1 rep max, and you want 3 seconds time under tension. Then once you get past that, you've got to get the tendon into impulse loading, or you've got to expose it to rapid bouts of high forces so it gets tolerant to being rapidly stretched or aggressively tugged on. So that tendon can regain its ability to act as a really robust string where it actually absorbs and releases force. So if we move on past exercise, which we know works pretty well for reactive tendinopathy and early to mid stage tendinopathy, you start to get into some of the other interventions like biologic and pharmacologic interventions. Anybody that's been paying attention over the last 20 years has seen a rapid rise in PRP. PRP contains growth factors that theoretically promote healing. They're best suited for, at least based on the research, they show the best outcomes for the early stage or reactive phase tendinopathy. But right now, it kind of has limited evidence for chronic tendinopathies. And I'm going to talk a little bit later about why I think that might be. And there's a couple of different factors that I think could play in here. I think that in theory, PRP has a ton of potential. I just don't think that we've harnessed that potential as good as we can yet. And then, of course, you have corticosteroid injections. They're great for short-term pain relief in, reactive tendinopathy, but they're a double-edged sword because they are just going to promote degeneration of the tendon. They are not healthy for connective tissue at all. And, you run the risk of increased tendon ruptures, actually promoting the degradation of the tendon and getting yourself in a position where you have even worse chronic tendinopathy when you're going to these corticosteroid injections. One of the other interventions that's gained a lot of popularity in recent years is shockwave therapy. So essentially using a super powerful, very focused ultrasonic wave to try to stimulate collagen growth, maybe try to spark a little bit of healing natively within the body. There's some decent evidence to support it in Achilles tendinopathy and plantar fasciitis, but it still needs a little bit deeper dive on it, and it definitely shows that it's going to work best if you compare it or if you pair it with exercise. One of the other options is actually ultrasound guided percutaneous tendon debridement or percutaneous tenotomies. So the concept behind these approaches are to remove degenerated parts of the tendon that are completely, unsalvageable, and in particular to remove that hypervascularization and that neural ingrowth around the paratendinous sheath that's making things so incredibly painful, and that's maybe actually kind of inhibiting some of the potential healing. So the concept is to attempt to strongly stimulate an innate healing response. So think about, and I'll talk about this example in a second, the ACL and the meniscus. So when you look at meniscal repairs, the research on meniscal repairs in isolation. So doc goes in, cuts open the knee, you got a meniscus tear, sew it up. The rates of healing on that meniscus are actually not super great. It doesn't heal super well. There's a lot of re-tears. Sometimes we're decent at it, but it doesn't even come close to the rate of healing that you see with a meniscal repair when it's paired with an ACL reconstruction. So when you look at ACL reconstructions with concomitant meniscal repairs, the rate of healing is multiple times better, and the long-term outcome for that meniscus repair is significantly better. And when you ask, well, why is that? Like, there's no difference. Like, you cut in there, you sew up the meniscus, or you cut in there and you fix the ACL and you sew up the meniscus. Well, the theory right now, which has the most, kind of weight behind it, is that when you drill through the bone, when the surgeon drills through the bone and tunnels to put in that ACL graft, they release a really robust innate healing response. So your body knows how to heal stuff better than science does at this point. For the most part, nature's done a pretty good job at figuring out how to heal stuff. So when we tunnel through that bone, we're releasing a ton of bleeding, we're releasing a ton of stem cells out of the bone. We're basically creating your own perfect version of PRP at that point. So this is the ideal. Well, PRP is really good, but maybe we're centrifuging it down just wrong. Maybe we don't have the right quantities of stuff. Maybe we're not getting it out of the bone, and maybe that's more helpful. So this concept that is, as we drill through the bone, we have an incredible ability to heal soft tissue. So with these type of interventions, like you see down on the bottom right side of this slide, that device is called the Ocelot device. It's TendoNova's approach to this. We're trying to strongly stimulate an innate healing response by causing some localized bleeding, by actually maybe scraping or tapping into the periosteum of the bone to release some healing factors there. So you guys have probably heard of most of these names. TenJet is probably maybe the most popular one that you see out there. TendoNova and 10X. There's some differences between those. TenJet, it uses a hydrocision device where they're using high pressure water to try to go in and maybe debride the tendon a little bit. It looks like maybe they're pretty decently effective, and the uptake of that device is becoming a lot more, and that approach is becoming a lot more common. But one of the problems I personally have from it, from a biological plausibility perspective, is if you're using an aggressive high-powered water jet to debride a tendon, you're going to get a washout effect. So maybe some of those really beautiful healing factors that are elicited with that local debridement that you're doing, that it's washed out by the high pressure water lavage that goes along with the TenJet approach. The 10X approach uses like an ultrasonic needle where it heats up, and I think maybe it vibrates a bit. And that one's kind of going out of fashion right now because there's been a lot of history of patients being burned by the needle, and the needle heating up and actually breaking off. There's a lot of case reports on that. I've seen a lot of people have successful outcomes with 10X and with 10Jet, of course. But I personally, and I'm biased, obviously, I'm doing the presentation for TendoNova. I just happen to think that their device seems to be it makes more sense to me from a biological plausibility perspective when I look across the board. And I always like to anchor what I'm doing, and when I rationalize something, to does this make sense from what I know about how tissues heal and how they respond to healing factors and how they respond to load. Um, these are good approaches. I've got a local physician close to me who does a ton of these type of procedures, and I've been lucky enough to see some of his patients afterwards for a rehab progression after they've had this. And to be honest, I was skeptical. I was pretty darn skeptical at first, and then these people just kept coming in and kept getting better. And it was working really well. And some folks that, maybe I was struggling with, that they had this procedure and they did well. So I started to like get a little bit interested and try to learn a little bit more about this. Talk to you guys about a couple of case studies later. And of course, we want to combine with exercise for the best results, right? You want to debride the tendon, you want to stimulate as much healing as possible, you want to get rid of the hypervascularization and the hyperneuralization that's driving so much of the pain, and then you want to apply load over the top of that with that innate healing response to try to actually heal the tendon, progress the tendon while they're feeling really good. And then the thing that we never want to get into, if we can avoid it, though it is only it is the only option sometimes, is a surgical intervention. These are the folks that have been, unresponsive to everything else, and you have to go in and mechanically debride the tendon with a surgical intervention. And I've worked with a few patients after surgical debridements of the lateral epicondylitis and medial epicondylitis presentation, and they've done really well, but it's a slower recovery. It's more invasive. The risk for negative effects is higher. The risk for infection is higher. So hopefully we can start getting to people faster, so they're not getting to this point of needing surgical and open debridement. Anytime we can do something without opening up a patient, that's going to be better for them. So let's talk about, what do you do when you have that patient in clinic and they're just not getting better? You are trying everything. They have this chronic patellar tendinopathy. They have this chronic plantar fasciitis. They have this chronic lateral epicondylitis, and you've been working with them for 3 or 4 months, and it's just staying the same. It's just not getting better. Because unfortunately, this is where we actually get a lot of people in rehab. We ended up seeing them way down the line. They have let it go for a long time themselves. Maybe they've been bounced around through the medical community. Maybe they went to their primary care. Primary care sent them somewhere else. They had an unnecessary image. They went to ortho. Ortho said, this is not a surgical case. Go ahead, go to PT. And at this point, it's been months. And we get these folks, and they're in that degenerative tendinopathy, degenerative disrepair of the tendon, and it can be really tough for these folks. So unfortunately, that stage is where we get to see most of our people, and we're successful with a lot of them, but there are some that it's a struggle. So obviously, I'm a fan personally, from what I've seen in my clinical experience of TendoNova and the Ocelot procedure, in particular because of these three things right here. Manually getting rid of the hypervascularization, manually getting rid of the neural ingrowth, and actually strongly attempting to stimulate that innate healing response without washing it out. So working on the paratendinous sheath, working on the tendon bone interface, doing some work on the periosteum, trying to stimulate some of the factors out of the bone and a localized healing response. Because we talked about earlier, in that chronic tendinopathy, you don't really see inflammation. And without inflammation, you can't really heal anything. So sometimes sparking inflammation might be a really good thing. And then again, just the reminder of that whole ACL reconstruction and meniscus, really trying to get that innate healing response. And then as we continue to get better and better with PRP, I think that that's going to be a good option, a good additional option as well. Once we really get the centrifuge techniques down and dial in on what might be the best for a person. But right now, I think that person's own natural healing response is probably pretty hard to rival. So if we take it back to the donut hole hypothesis, we've got a tendon that is no longer normal, right? You guys saw the normal tendon earlier. Now you've got all of this yellow and red around it. You got this yellow and red around the donut hole. Well, that's that hyperneuralization and hypervascularization that's driving so much of the pain. So we want to find a way to, desensitize that so we can actually open up the capacity for loading and, debriding the peritendinous sheath and getting in there and doing some actual physical work around the tendon is going to be helpful for that. And then maybe we can actually start to fill in those donut holes if we stimulate some bleeding in the area and we do a little bit of work to get that innate healing response ramped up. So the perfect scenario would be we get rid of the painful tissue, we get rid of the hyperneuralization, we stimulate some healing, we actually get maybe those donut holes to start filling in, and then we can use our loading approach to actually realign the collagen fibers and get this tendon to be fully healthy. A lot of times, pretty immediately after this procedure, people are feeling really good. They feel a lot better because we've taken away the peripheral sensitization with getting some of that debridement, which I know sounds counterintuitive. You're debriding a tissue and you're causing inflammation, but when you get rid of the hyperneuralization at the peritendinous sheath, people almost immediately start to feel quite a bit better. And then guess what we can do? We can start to load them. We can start to actually, put tension through the tendon and at least theoretically fill in those donut holes. And if nothing else, load that tendon a lot more with less pain. And that's going to help that person long term. So we're trying to spark that healing process, trying to fill in the donut if we can. And then just a quote from Keith Barr, I mentioned that he's a heck of a good tendon researcher. And inflammation is absolutely essential for adaptation, is a direct quote from him. And it applies in chronic tendinopathy. We just don't really have much inflammation. So sometimes maybe we can spark some inflammation to jumpstart things to get it going the right direction. So, just a little bit of background on the Ocelot device. I think it's pretty cool because one of the things that made me gravitate towards TendoNova is it was partially founded by a PT. Kelly mentioned that earlier. So somebody who understood loading, somebody who understood the value of exercising a tendon and stressing the body to positively adapt. And he was just burnt out on having people with chronic tendinopathy that he wasn't able to help. And he started brainstorming ideas like, how do I figure this out? How do I fix this? And that's where this idea came from. So it's the first, wireless ortho device, which is pretty cool. It's super lightweight. It's super easy. I've seen tons of videos of it working. I haven't gotten to see it in person yet. Just like in the office, takes 10 minutes, ultrasound guided, just taking care of stuff. It's pretty nifty. Um, and then, I created this spectrum or adapted this spectrum that I had seen to say, like, when do I think this might be an option for my patients? I'm kind of, adapting this into my practice as I've become more familiar with it. And I know folks using this procedure now, and I've seen some, some clinical case success with it. If I get somebody that's in the early stages or middle stages, I'm physical therapy, dude. I'm loading this guy. I'm trying to get them to take care of it with as little intervention as possible, reasonably. Um, but if I've got somebody that has just been stuck in that rut and they can't get out and they're spinning their wheels, and I've been working with them, I've been trying to load them, rather than wasting their time for 6 months and not getting anywhere, I'm getting a lot more quick to say, you know what, you should consider this procedure. It's really fast. It's really affordable. It can be done in the office most of the time, and then maybe we can actually make your rehab, your loading a lot more effective, a lot quicker right after this. So kind of in that, like you're getting into that chronic degenerative stage and people seem to be a little bit more recalcitrant. I'm starting to recognize, still trying to figure out exactly when the right time to refer is, but I'm referring earlier now than I was earlier in my career. When I was a young PT, I felt like I could fix everything. Like, I don't want to refer anybody anywhere because I can take care of it. I can do it. I can fix, PTs are magic workers or whatever. I've gotten a little bit more humble now after I have, not been able to help folks, and I've seen that presentation, and I'm like, oh man, I don't know if this is going to be the guy that I can get over the hump, and I don't want him to spin his wheels. and waste his money or waste his time or heartache for 4, 5, 6 months. I would rather them maybe get in a little bit quicker, and then we can actually get a more effective loading program going for them afterwards, and shorten their entire window of recovery by quite a bit. Um, so I kind of alluded to this earlier, like why do I personally prefer TendoNova? I'm biased. I think it's super cool that it was started by a PT, and I've talked to Jonathan a lot, and he gets it. He understands it, and we speak the same language, so that has definitely opened up my eyes. No incision. I mean, anytime you don't have to make an incision, you don't have to use sutures, that's a positive check mark. You're reducing the likelihood of infection, you're reducing the invasiveness. I mean, we can just see the research. If you compare an open rotator cuff versus an arthroscopic rotator cuff, or an open ACL reconstruction versus an arthroscopic ACL reconstruction, if you don't have to open a person up, the outcomes are better. Their recovery is faster. It's been proven time and time again. Um, I kind of like the as I mentioned earlier, the no saline washout effect, So I personally want as much innate healing potential as possible for that tendon. I want that inflammation there. I don't want to wash out any growth factor. And then no risk of burns, when you're using a hypersonic device, a powerful ultrasonic device. It that's just a little bit worrisome when you read some of those case studies. So personally, for me, I would lean away from that. But again, I'm not the one doing the procedure. I'm just the one seeing the patients before and after. Um, and then one of the big things that I think is huge is that TendoNova puts a really strong emphasis on post-procedural rehab and loading. So they're not just saying, that loading is no good and PT suck and rehab isn't effective. They're like, hey, let's pair this together. Let's get it done for patients faster and be more effective, and tag team this approach. And I think it's is really positive. So yeah, you're like, oh my God, like, there's a bunch of PTs on this, and like, what did this PT guy just say? Like, he's in favor of a procedure and he's in favor of referring out. Like, yeah, actually, I am in this case because of, this is just a couple of the case studies I've seen. I had this guy last year named Bill. We'll call him Bill. He was a software developer. He had like just chronic 9 months, I think, by the time that I was seeing him, of lateral epicondylitis. He's, typing all day, but he liked to play a little bit of tennis and he liked to do various things like that. And he just could not get it to go away. He had over the counters, he had prescription steroids, he had tried activity modification. He's wearing his little counterforce brace all the time. We tried PT for, I think it was like close to like 3 months, and he just wasn't getting anywhere. And he was doing his stuff at home. He would send me text messages like, "Dude, look at me. I'm doing my eccentric loading. Like, I got my TheraBar. I got him to like order a TheraBar and do his things and stuff at home." He just wasn't getting better. And then finally, I was like, "Hey, man, like, I got this guy. He's doing these procedures. Maybe you should go talk to him." Uh, so Bill does. He's like, "Okay, this sounds cool. I've been spinning my wheels. I'll give this a try." And it kind of pissed me off, to be honest with you, because I had been working my butt off with this guy, and he goes and has this procedure. He has like, 1 to 2 weeks of rest and like some gentle stretching and some gentle isometrics. We come in and start loading him, and he's immediately got less pain than he did before I sent him for the procedure. And I'm like, okay, well, this is kind of interesting. Like, what the heck's going on here? Like, how does he have less pain already? And then we start loading him up pretty fast. At week 5 and 6, I'm getting pretty aggressive exercise. We start doing pretty heavy wrist curls and wrist extensions. I'm having him do loaded carries, something that was really tough, like carrying in his briefcase, because he carried around this dude was kind of strange, carried around a briefcase with a computer all the time. And that was killing his forearm. He would start doing loaded carries with like a 45-pound kettlebell. And he's like, "Yeah, this is great, man. This is awesome." So then we get to tennis, racket sports. He starts backhanding in the clinic. I'm throwing the birdie at him. He's hitting it with the badminton racket. He's hitting it with the tennis racket. And I start throwing heavy balls at him. He's able to tolerate it really well. So spinning my wheels for 3 months with this dude, and then he has this procedure, and 8 weeks later, he's back to dramatically higher levels of activity that he's been in the previous 9 months with less pain. And at that point, like, it piqued my interest. I started to say, maybe there's something here. Maybe something's going on. Then a few months later, I had this other lady come in. She's got chronic plantar fasciitis. It's just blasting her. She's got an ice pick in her heel first step every morning. It's been going on for months and months and months, and she can't get it better. She's bought like 17 different pairs of shoes. She tried the rocker bottoms. She tried her Hokas. She was trying, like the little orthotic sandals and all of that sort of stuff. Couldn't get this to go better. Um, so I start working with her for a couple of months, and she's really diligent on, doing her exercises. She's staying on top of it. She wants it to go away. I've got her sold that I can fix this thing in 2 months, and she is 0% better. And I'm like, okay, all right, like I know this guy. Like maybe go talk to him and see. And she goes, ends up having the procedure done. And this one was even faster. At 7 weeks afterwards, she's back on the treadmill and she's running. And she's putting in like 12 to 15 minutes of running. And she hadn't been able to run for like longer than a minute and a half before that. So then I start to be like a little bit of a believer and I'm getting frustrated. I'm like, what the heck is going on? Like, do I suck as a PT? Like, I don't think that I do. I put a lot of effort into not being your average Joe PT. And, I got humbled again. So had her pain drop from, first step morning pain from 7 out of 10 to 1 out of 10. And I'm like, golly, dude, okay, I'm a little bit more interested. And that's kind of when around about the time I was getting connected with Jonathan and learning a little bit more about, TendoNova as a whole. And, that's how we sparked this relationship. And that's how I ended up as somebody on the medical advisory board because we were speaking the same language. I was like, man, like I think this is pretty cool. And I think I can lend a lot of help from, if people are reaching out to me about developing, you want to know a protocol for how I approached tendinopathy loading, before and after these procedures. I've dug pretty deeply into the research on tendinopathy. Hopefully, just this little overview gave you some insight that it's not something that I take lightly, and it's something that I've looked really deeply into. So it's something I have a lot of passion about, and I wanted to be involved in, and I wanted to champion, the PT and rehab side of things, and how it can be very, cohesive with each other. So, summary of the key points. Tendinopathy is super complex, and it is a lot more than just tendon inflammation. Progressive loading, especially for the early stages, is gold standard. But late stage tendinopathy is a lot more difficult. It's a lot less responsive. So maybe we got to look at other options. Biologic therapies like PRP have mixed evidence. They should be used selectively. I'm not saying they shouldn't be used. I'm a believer in the thought process and the theory behind PRP for sure. Corticosteroid injections, in my opinion, really don't use them unless you absolutely have to. There's just not a lot of positive things to say about what they do to connective tissue health. But I understand that people sometimes need to be out of pain for one reason or another. Minimally invasive treatments like the percutaneous tendon debridement definitely show promise. I've seen some pretty cool clinical case studies, and we should definitely consider them for chronic cases. I'm a pretty good believer in the biological plausibility of addressing the hyperneuralization and stimulating an innate healing response to improve loading, and then continue to maybe fill in those donut holes and realign the collagen fibers, make the tendon healthier as a whole. Then definitely load it up a little bit afterwards. So that is my stance on tendinopathy in a nutshell, and a really good overview. Now, of course, we could go down into the nitty gritty and we could really start talking about some of the histological studies and various things like that. But I feel like this was a really good overview, and I'd be interested to hear what questions you guys have. And just so you have evidence that I didn't just pull all this stuff out of thin air. Here are all the references that I would strongly encourage you guys to go read. And then wanted to thank you for spending this time with me. I know that it is, a Thursday night and you have a lot of things that you could probably be doing instead, but, I appreciate you guys listening to me talk about tendons. So let's go into some
Great.
question and answers.
Thank you so much, Jarod. I know I learned a lot. And yeah, now we'll go into the Q&A session. If you haven't already, please go ahead and enter your questions into the chat. And I've already got some pulled up here from some people that sent some in during the presentation. So we'll just get started with those. Someone asked, you said that there's 40 million sufferers of tendinopathy. Is that just in the United States or is that worldwide?
That is just in the United States.
Wow. Okay.
Yeah.
That's a lot more than I thought too.
Yeah, I was shocked when I really started digging into the prevalence rates. I was like, oh my gosh, like I know I treat a lot of people with tendon issues, but the truth of the matter is there's a lot of people who just deal with it chronically and they don't get care as well. And a lot of people that I don't see. But if you, man, it's a ton of folks.
Definitely. This person asked, I'm not familiar with percutaneous debridement. This is new to me. Is this something that insurance is covering?
Well, so I think that that's going to be on a case by case basis, and I think Jonathan maybe is still on this call, or maybe Kelly, you can answer this in more detail. What I don't want to do is put my foot in my mouth, but yes, in a lot of cases it is being covered. But I know that there are some nuances to that, but I don't want to speak out of turn.
And yeah, Jared's right. I can only speak to the coverage for TendoNova alone, not the other devices. But yes, insurance is covering the TendoNova procedure. Our next question is, I want to know how TendoNova works for larger areas, especially the glutes, and when to use it for tendons aside from the Achilles.
Yeah, so I just use, like the Achilles as a really conceptual model because I think it's a big, large tendon that everybody, you can physically touch and you can see it really well. But those same principles in general apply to most tendons. Now, if you talk to a tendon researcher, they will say there's some nuances in the collagen structure and the makeup of different tendons throughout the body. Like the patellar tendon has a little bit different collagen makeup than the Achilles tendon and the gluteus medius tendon. But in general, this is it's a really good option for that same thing that occurs in chronic insertional gluteus medius tendinopathy, medial lateral epicondylitis, plantar fasciopathy, I guess I should say. And I've actually seen some case studies on the patellar tendon as well. So I don't think that it's just restricted to the Achilles at all by any means.
Great. This person asked, how do you know when it's time to refer a patient back to the doctor to consider percutaneous tenotomy or debridement?
Yeah, that's a good question. I'm still, trying to figure out exactly what that looks like. I think it's probably different for different people. I'm gonna look at the person's entire like history of this occurring, and do I think that this is chronic? Is this acute on chronic? Like it's been a problem forever, and now I'm just seeing them because it's super flared up. What is their metabolic presentation? Like, what is their general health? Like, if they're really metabolically unhealthy, do I think I'm going to be able to stimulate enough healing and progress in clinic? Like maybe, maybe not. And then do I see them responding pretty quickly in clinic? If I don't see them responding relatively quickly, I'm a little bit faster to make that decision to maybe refer now than I was, especially if I'm classifying them in that like chronic, like kind of almost recalcitrant category off the bat. So that's one of my slides was a little bit of a workflow on like if it's here, here, or here, like, hey, this is physical therapy. If it's, acute stage or that reactive tendinopathy or, maybe moderate, maybe I'm starting to consider that if it's getting into that chronic stage and it's something they've been dealing with for a long time and I don't seem to be making any headway, quickly.
Great. All right, next question. They asked, do you use any specific loading parameters, so intensity, volume, or frequency, to optimize remodeling?
Yeah, so I alluded to that on the slide where I was talking about 6% tendon strain. So what that indicates is you want to go through pretty much a full range of motion, and you need to have 75+% of one rep max to really stimulate any collagen production. So a lot of our rehab programs historically are doing your 3 sets of 10 with an RPE of like 4. We're probably not stimulating any tendon changes there, and we're probably not really helping that person all that much. So I'm definitely going to try to zero in on the load that I know will stimulate collagen production and collagen realignment, and then it's going to be layered in to a person's tolerance. So there's a really good rehab provider in the UK. His name is Ben Cormack, and he came up with this concept called the rule of tens. And the rule of tens is like your intensity and a person's pain level should add up to 10. So if a person's pain level is like 3 out of 10, you can try to get your intensity or their RPE up to a 7 out of 10. So those things should add up to 10. So if their pain levels are at a 9, you're probably going to have to be pretty low on the intensity, at least until the pain levels come down. And that's not like an end all be all, but it's a really good rule of thumb that you can use to progress somebody and increase intensity as the pain levels kind of come down. And again, they call that the rule of tens.
Great. And the next question is, how do you minimize flare-ups while progressively loading, especially in a sensitive case?
Yeah, so I mean, that's always going to be paying really close attention to within session volume and between session volume, paying attention to all of the activities that a person does outside of clinic. Because if you look at people in a vacuum of just what you're doing in the clinic and you ignore all the activity they're doing out of the clinic, then you're probably going to end up overloading them or not loading them correctly because you're not taking into account the full dosage of load that they're putting on their body throughout, everyday life. So what I want to do is understand that first. And then I want to always take note of what's your pain level during and immediately after exercise, and then what's the pain level for the next 24 hours. And if they're sore and it goes up to, let's say, like a 3 or 4 out of 10 over the next 24 hours, but it's back down to their baseline after that, I consider that a really good level of loading. But if it flares up to a 7, 8, 9, 10, and it lingers for 3 or 4 days, well, I've definitely overloaded them at that point. And unfortunately, that's what ends up happening a lot in those really chronic hypersensitized tendinopathies is they have so much neural ingrowth that their response is really aggressive and they get really high pain levels as soon as you load them, and they'll linger because you have this peripherally sensitized neural pathway. And then again, it's really tough to get them the intensity of load that they need with that much pain.
All right. And our next question is there a specific timeline that is considered early phase or mid phase or past that?
So usually, I mean, you can say arbitrary timelines. I try not to put arbitrary timelines on things, but usually early phase is you've got that reactive tendinopathy that's happened within the last month. That mid phase is somebody that's been having a tendon problem for somewhere between like 2 to 3 or 4 months. And then that late stage or chronic is it's been hanging around longer than that. If it's been going on for 5, 6, 7, 8, 9 months, then that's definitely a chronic issue because they've not had the healing occur and their inflammatory process is likely stalled out at that point.
Okay. And this person asked, how does this treatment, I'm assuming they're referring to TendoNova, how does this method dose inflammation to find the sweet spot of inflammation necessary to promote adaptation and healing without impinging on loading and progress?
Yeah, I mean that's a good question, and I think you have to think about it through the lens of just what happens in a normal injury. Like let's say if I strain a muscle, so I get a partial tear in a muscle or something like that, I'm going to have a pretty aggressive amount of inflammation. But that inflammation, if it's controlled, naturally by my body in a relatively healthy environment, is probably not going to get out of hand. And again, Keith Barr's words are you need inflammation for healing. You literally cannot have adaptation without inflammation. So going in, and again, I don't want anybody to think about this procedure like they're just going in and just like gouging holes in a tendon. That's not what's going on here. They're going in and selectively targeting, what is the peritendinous sheath and the most degenerated areas, and then again trying to stimulate some release from the bone and the periosteum there. So that amount of debridement is not very extreme. It's not super excessive. This isn't like a going in and blasting a tendon type of procedure. This is kind of sparking that more natural, normal type of healing that you would expect to see.
Great. Um, and let's see. Does the general time frame for when to resume loading a patient post tendon treatment ever differ? For example, depending on which tendon was treated.
So far, I haven't done any difference in the loading. Usually it's, a week or two of just general rest and light isometrics and light stretching. in latter days, we used to, um, or early days, we used to like completely unload a person and say, well, you had this thing, you need to not load it at all. You had a muscle strain, you had a muscle tear. We need to like rest you up for 5 or 6 weeks before you start to stretch or load this thing. Now all the new evidence is showing like the earlier we can start loading, the better. The earlier you can start putting tension on a healing tissue, the better. The more organized the fibers lay down, the quicker they actually start to get a little bit stronger. So, I mean, past the initial post-procedural like soreness and like, hey, let's let the little like needle hole close up and let's let them chill out for just a second because they did have a debridement procedure. You're pretty quickly wanting to start putting a little bit of load through it, the isometrics and the gentle stretches and that sort of thing.
Great. And then we're just going to do one last question. I have some more, but for time purposes, we'll wrap up with this one here. This person asked that in your experience, rehabbing post-tendinova treatment, do you feel like you've been able to load them better with less pain because of the mentioning of them having less pain after the procedure?
Yeah, like 100%. That's what like got my attention is when I was loading somebody and they were having an 8 out of 10 pain. They have the procedure and 2 weeks later, 2.5 weeks later, I'm loading them with the same exact exercise and they're having like a 2 out of 10 pain, 1 out of 10 pain. That's what got my attention. I was like, let me dig into this a little bit more.
Awesome. Well, we'll wrap up there for the night. Thank you, Jarod. And thank you, everyone, for joining us tonight. We hope you learned something new and found this to be beneficial. I know I did. We'll also be sending out a recording of this webinar to all of you once we have that ready to go. And that's it. So I hope everyone has a great night. And thanks for coming.
Appreciate it, guys.